Leukopenia. So leukopenia means the WBC count is decreased. So neutropenia means neutrophils are decreased. Lymphopenia means lymphocytes are decreased. Eosinophilia means eosinophils are decreased. So we need to count that neutropenia means less than 1500 cells. In the case of severe infection, less than 500 cells. Lymphopenia, absolute lymphocyte count will be less than 1500. Less than 3000 is seen in children, and eosinopenia means less than 30 cells. So what are the causes of neutropenia? You can see here sepsis after infection, or because of drugs, or aplastic anemia, SLE, radiation, and congenital. And lymphopenia is due to HIV, Dye-George syndrome, SCID, SLE, glucocorticoids, radiation, sepsis, postoperative. Eosinopenia means Cushing syndrome, glucocorticoids. One thing you need to remember that glucocorticoids can cause neutrophilia but not neutropenia, but it can cause lymphopenia and eosinopenia. You can see here clearly. So they decrease the activation of neutrophil adhesion molecules, impairing migration out of vasculature to the sites of inflammation. Actually, glucocorticoids don't allow the neutrophils to migrate out of vasculature. Okay, in contrast, glucocorticoids sequester eosinophils in lymph nodes and cause apoptosis of lymphocytes. So lymphocytes and eosinophils are decreased, but the neutrophils are not decreased in the case of usage of glucocorticoids. So next we are going to discuss about the heme synthesis, porphyras, and lead poisoning. Already we discussed lead poisoning, but again it is repeated here because it is related to this diagram. By this diagram you can clearly understand. So first thing is whenever there is inhibition of LR dehydrase and inhibition of ferrochelatase, okay, when these both enzymes are deleted or inhibited, that is due to lead poisoning, and this will lead to accumulation of protoporphyrin because protoporphyrin levels will increase, and also LR will increase in the blood. So actually it is causing microcytic anemia. We know already lead poisoning will cause microcytic anemia, and also it will cause basophilic stippling. You can see the stippling here that is seen in lead poisoning, and you will see the ring sideroblasts in bone marrow and GI kidney disease. Also causes in children, exposure to lead will cause mental deterioration. In adults it may lead to headache, memory loss, demyelination, that is peripheral neuropathy. So next, coming to acute intermittent porphyria. In this diagram you can see here, this is acute intermittent porphyria. Here this step is inhibited, that is a porphobilinogen deaminase is inhibited. So because of that, what happens is porphobilinogen and ALA will get accumulated in the body. Okay, so there are 5 symptoms associated with this. You can remember it with 5 P's. So acute intermittent porphyria, 5 P's: painful abdomen, port wine colored pee, polyneuropathy, psychological disturbance precipitated by factors increased LR synthase like drugs, C5P 450 induces alcohol, starvation. So treatment is hemine and glucose inhibit hepatic delta LR synthase. That is we need to also inhibit this process, rate limiting step, so that this protoporphyrin will not get accumulated. So most common cause in adults 30 to 40 years, recurrent abdominal pain and confusion. So actually this porphobilinogen and LR are neurotoxins, so that's why in treatment we are inhibiting this LR synthase so that this porphobilinogen will not accumulate in acute intermittent porphyria. Next, coming to porphyria cutanea tarta. So here there is Europe for porphyrogen decarboxylase is inhibited. This is the most common porphyria. So we discussed as 3 types of porphyria. That is lead poisoning is related to this, and also acute intermittent porphyria, porphyria cutanea tarda. Porphyria cutanea tarda is the most common porphyria. Here this enzyme is inhibiting. This is the 5th enzyme in heme synthesis pathway. Okay, so this will lead to accumulation of uroporphyrin. Actually it is a tea colored, which you can see in urine. So tea colored urine is seen in uroporphyrin. Here liver enzymes like AST, ALT are also elevated. Okay, and blistering cutaneous photosensitivity, hyperpigmentation can be seen. You can see this is a blistering cutaneous hyperpigmentation. And this is most common porphyria exacerbated with alcohol consumption, hepatitis C, HIV. There are familial causes and also hepatitis C. Treatment: phlebotomy, sun avoidance, antimalarials like hydrochloroquine. Now let us discuss iron poisoning. Iron poisoning is divided into acute and chronic iron poisoning. So acute iron poisoning is like high mortality rate with accidental ingestion by children. So mainly children who are taking more iron tablets, just like a candy like that. Okay, so this will lead to cell death due to formation of free radicals. So what is the problem here is that iron which is taken in, it is causing free radicals and leading to peroxidation of membrane lipids, and this is causing abdominal pain, vomiting, GI bleeding. Radio opaque pill is seen on X-ray. So if you see the X-ray, you can see that, and it may progress to anion gap, metabolic acidosis, multi-organ failure, scarring with GI obstruction. So treatment is chelation, deferoxamine, defrixo, and gastric lavage can be done. Coming to chronic iron poisoning, it is seen in patients with primary hereditary or secondary chronic blood transfusion for thalassemia or sickle cell disease, and also hemochromatosis. So this is a chronic form which is seen in hereditary and also chronic blood transfusion for thalassemia or sickle cell disease, hemochromatosis. Symptoms are arthropathy, cirrhosis, cardiomyopathy, diabetes, skin pigmentation, that is bronze diabetes, hypogonadism. Treatment is phlebotomy, patients without anemia or chelation. This is best. Now coming to coagulation disorders, actually abnormal platelets can be seen in the skin mucosa as pechiae. Abnormal coagulation factors are seen in the joint and deep tissue bleeding. Very important. When the coagulation factors are abnormal, you'll see it in joint and deep tissues. But when platelets are abnormal, you can see in the superficial like mucosa pechiae. Okay. So coagulation disorders are PT, and it is based on PT and PTT. If you remember, we measure PT for few factors and PTT for few factors. PTT will see for especially intrinsic pathway and PT for extrinsic pathway. So PT test is common, extrinsic pathway for factors 1, 2, 5, 7 and 10. Actually these factors are also related to vitamin K, right? Vitamin K. So defects increase PT, okay, extrinsic pathway. INR is a patient control PT is 1 equal to normal greater than 1 prolonged. So most common used to follow patients on warfarin which prolongs INR. So in warfarin we'll check for INR. Next PTT test is common for intrinsic pathways, okay, for all factors except 7 and 13. Okay, next coming to coagulation disorders, actually they occur in association with malignancy, postpartum, autoimmune disorders. This can be due to clotting factor deficiencies or some acquired factor inhibitors, most commonly against factor 8. So these coagulation disorders are against factor 8. They diagnose with mixing study in which normal plasma is added to patient's plasma. Clotting factor deficiency should correct the PT or PTT return to within appropriate normal range, whereas factor inhibitors will not current. Treatment is prednisone. Actually here what we do is what they mean is, actually if we in this mixing study what we do is we normally add the normal factors and the factors which are deficient in that. If we add this both, after some time it should become normal. The plasma is added to the patient, clotting factor deficiency should correct. If it is getting corrected, then you can say it's coagulation disorder. If it is not getting corrected, it means there are some antibodies against it, so that they are inhibiting it to not correct. Okay, so now coming to hemophilia A, B, C and vitamin K deficiency. In hemophilia A, B, C, actually if you remember, hemophilia A means factor 8 deficiency, hemophilia B means factor 9, and hemophilia C means factor 11 deficiency. So if these factors you can see 8, 9 and 11. 8 is related to intrinsic factor, right? 9 is also related to intrinsic factor and 11 is also intrinsic factor. So here you can see the PTT will increase because it is related to intrinsic factor. PT will be normal. So intrinsic pathway coagulation defect: A for 8, X-linked recessive, hemophilia 8, B for 9, X-linked recessive, C for 11, autosomal recessive. So hemorrhage in hemophilia will lead to hemarthrosis, that is bleeding into joints. Example, in the knee you can see hemarthrosis, easy bruising, bleeding after trauma, surgery, especially after dental procedures, because these factors are lost. 8, 9, 11, so there will be no intrinsic pathway, so that will lead to bleeding. Okay, and the treatment is desmopressin factor 8 concentrate, because factor 8 is not present in the case of hemophilia A, or you can give emixubab, or factor 9 concentrate in the case of hemophilia B, or you can give factor 11 concentrated in the case of hemophilia C. So actually these factors are not present, so that the fibrinogen can't convert into fibrin and it can't form a mesh like structure. So because of that there will be bleeding. So whenever there is any dental procedure, after all that, if you see bleeding, then you should think about this hemophilia A, B or C. If their factors are deficient, only PTT will increase. That is very important because it is related to intrinsic activity. The side effect will be flushing and headache. Now coming to vitamin K deficiency. In vitamin K deficiency, you can see factor 2, 7, 9, 10 are involved. Here factor 9 is related to internal, factor 7 is leading to the extrinsic pathway. So here extrinsic and intrinsic both are involved. So both PT and PTT will be increased. That is important. Okay. uh, Actually protein C and protein S activities also decrease when there is vitamin K deficiency, because vitamin K, they are all dependent on vitamin K like 2, 7, 9, 10, C and S. So causes are warfarin, antibiotics, newborn, malabsorption in all these cases. So bleeding time is a test for platelet function, and treatment is fresh frozen plasma. So whenever there's vitamin K deficiency, we should give fresh frozen plasma. Whenever there's liver disease, there's loss of clotting factors, so it may cause thrombocytopenia. But remember, whenever there is liver disease, still the factor 8 will be present. Why factor 8 will be present? Because this is the only factor which is coming from the endothelium. Okay, so this may cause thrombocytopenia, that is decreased platelets. Now let us continue with platelet disorders. So platelet disorders, in every platelet disorders, the bleeding time will increase. Of course, you can understand if platelet is not there, the bleeding will be more, right? Especially you can see that in mucous membrane, microhemorrhages. Okay. Uh, Let us start with one by one. First is Bernard Solier. Actually, in this there is deficiency of GP1B. If there is no GP1B, I already discussed, there is no addition of platelet to 1 Willebrand factor, right? So that will lead to big platelets and also thrombocytopenia. So actually here the bleeding time will increase, but the platelet count may be normal or sometimes decrease. Okay, next coming to Glanzmann thrombasthenia. Here the problem is the GP2B 3A is decreased. If this is decreased, you can understand platelet to platelet there will be no aggregation and no platelet plug formation, right? So here the bleeding time will increase because no platelet plug, but the platelet count will be normal. If platelets are not aggregating, the platelet count will be normal, can be normal, right? So now coming to immune, actually this both are inherited conditions. Okay, and there is one more thing called Wiskott Aldrich, where there is VAS gene defect. Because of that decreased gene, there is immune dysfunction and also platelets are decreased, and that is leading to eczema, and that is triad. So what is the triad? Immune dysfunction because of remember like that, immune dysfunction, low platelets, eczema, that is a Wiskott Aldrich with there is VAS gene is defective. Now coming to immune thrombocytopenia. Immune thrombocytopenia is also called ITP. Okay, so here the bleeding time is increased, the platelet count is decreased. Why the platelet count is decreased? Because actually here the platelets, there is a problem that the platelets are getting distracted in the spleen because of the antibody, that is a anti-GP2B3A antibodies. So because of that, the splenic macrophages are trying to eat the platelets. So it may be idiopathic or due to some secondary to autoimmune disorders like SLE, viral illness like HIV, HCV, malignancy, drug reactions. So in the lab you will see mainly increased megakaryocytes because the platelets are destroying, right, on the bone marrow, and there is decreased platelet count. Sure, this is very important. So till now we have said platelet count is normal, but here the platelet count will be decreased because the spleen is eating the platelets. Okay, so immune thrombocytopenia, that why the name immune? Because here the antibodies affecting. Thrombocytopenia, you can see here, that is the decrease. In the name itself you'll understand everything. Platelet count is decreased, okay, because of some autoantibodies. Treatment is glucocorticoids, or you can induce IVIG antibody. Why you are giving IVIG antibody? Because this is an antibody, it will go and act on this instead of acting on the platelets, right? And also you can give rituximab, TPO receptor agonist, and also better to do splenectomy. If you do splenectomy, there is no spleen to eat the platelets, so platelet will be normal. Okay, so according to heading only you can understand clearly here immune thrombocytopenia, so thrombocytes are decreased here, but here they may be normal. Now coming to uremic platelet dysfunction, there's a platelet is dysfunction here because uremic. What is uremic? Let us see. It is because involving the renal failure, uremic toxic accumulate and interfere with platelet attention. So there are some toxins which are coming from kidney because of renal failure, and that is intervening with platelet adhesion. So as there is no platelet adhesion, here also bleeding time increase, but platelet count is normal. Now coming to thrombotic microangiopathy. In the name itself, you can see thrombotic means there is some thrombus forming. Microangiopathic means very narrow blood vessel, and there is thrombus. So now you can understand if the blood vessel is passing through it, it may have a chance to form the schistiocytes here. Okay, so thrombotic thrombocytic purpura. So it is a typically female. Inhibition of Adams T13, that is decreasing degradation of von Willebrand multimass. So increase von Willebrand multimass, increase platelet adhesion, aggregation, microthrombi formation. So this triad of thrombocytopenia, that is decreased platelets, microangiopathic hemolytic anemia, that is because formation of schistiocytes. You can understand if there is a thrombi like this and the blood cell want to pass through it, it will cut down into small pieces, that is leading to microangiopathic hemolytic anemia. There will be decreased platelets. Why decreased platelets? Because you can understand all the platelets are used up in forming that thrombus. And also acute kidney injury. Okay, and you can see PET because of low platelets. So triad, fever plus neurological symptoms, but the PT and PTT are normal, which help distinguish TTP and HUS. What is HUS? I'll discuss. In PT, very important. PT and PTT are normal because you can see there are like no coagulation factors involved here. Okay, DIC is activated, coagulation pathway is activated, so there may be DIC. Coagulation pathway is not activated in the case of what I mean, like in TTP and HUS, coagulation pathway is not activated for sure, because you can see there are no coagulation factors. But in DIC, coagulation factor is activated. Let us see DIC next. Okay, and important in TTP, D dimer will increase. Why D dimer will increase? If you remember, if the if the fibrin plaque forms and if it degrades, next it forms FTP and D dimer. Here D dimer forms because as you can see it is passing through this tumor and narrow blood vessel. Uh, some of the fibrin mesh may, the mesh which is formed here, the clot which is formed here, it may degrade later and it will increase the D dimer. Okay, next treatment is plasma exchange and also glucocorticoids and rituximab. Okay, so now this is kind of hemolytic uremic syndrome. What is this? Hemolytic blood vessel is breaking down, blood cell is breaking down. Uremic syndrome, typically children, caused by Shiga toxins like Escherichia coli infection, which cause profound endothelial dysfunction. And the same thing here, the same thing going, but the bloody diarrhea is present here. You're having a supportive care. So how to differentiate all these diseases? ITP, immune thrombocytopenia. Here platelets are dropped. In the name itself you can say thrombocytopenia. TTP, TTP is what? Thrombotic thrombocytopenic purpura. In the name itself you can say thrombotic, there is formation of thrombus. Thrombocytopenic, here also platelets are decreasing. Why they are decreasing? Because they are used up to form the thrombus. And purpura. Okay, so decreased platelets and hemolytic anemia. Why hemolytic anemia? You understood that concept, because of passing through that narrow and the thrombotic area, schistocytes are formed. The same scene is also seen in HUS. Okay, but in HUS, remember, there will also be bloody diarrhea because of involved Escherichia coli in the GI tract. And DIC. DIC next I'll discuss. In DIC, what happens is platelets are decreased because they are forming one clot. There will be hemolytic anemia, the same thing, because they are passing through that. And here increase PT and PTT because their coagulation factors are involved in DIC. But here the PT, PTT are normal because no coagulation factors are involved. Okay. Uremia, renal dysfunction, bleeding, increase bleeding time, normal platelet count, normal coagulation. This is very important. In uremia, there is renal dysfunction, uh, but the bleeding time is increased. But the platelets are normal and the coagulation is also normal, but there is poor aggregation or adhesion. Because of poor aggregation of adhesion only, the bleeding time is increasing. Everything is normal, but the platelet aggregation is not forming. If platelet aggregation is taking longer time to form, then of course the bleeding time will increase, right? So bleeding will be present because of renal dysfunction, that is uremia. The key point is cystocytes. Cystocytes are seen in all TTP, HUS and DIC. Okay. So now let us go to von Willebrand disease. In the name itself, you can see von Willebrand disease means von Willebrand factor may not be present, right? It can cause iron deficiency, anemia. So what happens here is the intrinsic pathway coagulation defect, that is decrease von Willebrand factor, so that increase PTT. Why increase PTT? Because intrinsic pathway is affected. Intrinsic pathway. So that's why in DIC I am saying PT and PTT are affected. Okay. So defect in platelet plaque formation, decrease von Willebrand, defect in platelet to von Willebrand adhesion, and mild but most common inherited bleeding disorder, no platelet aggregation, and treatment is desmopressin, which releases von Willebrand stored in endothelium. Okay. And also you can give aminocaproic acid, which inhibits the plasmin. So you can see why we give aminocaproic acid, which inhibit plasmin. Like why we are inhibiting plasmin? Because we don't want to break the clot which is already formed, right? So that even that clot can prevent at least some amount of bleeding. So here the lab values will be, platelet count will be normal because there's nothing disturbing platelet count. The bleeding time will increase because here the clot is not forming properly, and PT will be normal because PT, it affects the extrinsic pathway, right? PTT will be affected because here the intrinsic pathway is affected. Very important. So in von Willebrand disease, intrinsic factors are involved. Next, coming to DIC. In DIC, the platelet count is decreased because it is forming a clot. Bleeding time is increased. Even though it is forming a clot, bleeding time is increased because all of the clotting factors are involved there, and remaining are lost. So bleeding time will increase. And PT is increasing, PTT is increasing, means I think both extrinsic and intrinsic pathways are involved here. So it's a clotting factor activation, thromboembolic state, excessive clotting, consumption of so increased thrombosis, increased hemorrhage, and maybe acute life-threatening chronic if clotting factor production can compensate for consumption. Okay. So the causes are, you can remember this, SSS, triple S top. Okay. That is heat stroke, snake bite, because snake bite, thrombin like glycoprotein can cause clotting, in sepsis, in trauma, obstetric complication, pancreatitis, malignancy, nephrotic syndrome, transfusion, making new thrombi, promyelocytic leukemia, cystocytes. In labs, you can see cystocyte products, decrease fibrinogen, decrease factor 5 and factor 8. Factor 5 and factor 8 are decreased. Increased D-dimers treatment, fresh frozen plasma, RBC, platelets, and also you can give cryoprecipitate. Okay. So here you can see disseminated intravascular coagulation, there is ischemia, and there is also anemia. So next, coming to Hades syndrome. Here there is GI bleeding which is associated with aortic stenosis. There is angiodysplasia in GI tract, deficiency of von Willebrand factor, and that is uncoiling of Willebrand multiplex, explores the cleavage site for adamantium, improve after aortic valve surgery. Let us continue with hereditary thrombophilias. So hereditary thrombophilias, in the name itself you can say it's a hereditary condition, autosomal dominant, resulting in hypercoagulable state, that is increased tendency to develop thrombosis. So thrombopenia means decreased thrombocytes, thrombophilia means increased number of thrombocytes. So if more number of platelets are increased, what happens? They are increasing chance of thrombosis. Okay. So it is seen especially in antithrombin deficiency because there is a antithrombin. Actually it is mainly heparin uses this antithrombin by increasing PTT. You can see here can also be acquired like renal failure or nephrotic syndrome, antithrombin loss in urine, decrease inhibition of factors 2A and 10A. So when these 2A 10A factors are inhibited, there will be no formation of platelet plug, right? So why we use heparin is an anticoagulant, right? So this works as anticoagulant. Next, factor 5 Leiden. It is a production of mutant factor 5 where the guanine is substituted to adenine point mutation that is resistant to degradation by active protein C. So complications include DVT, cerebral vein thrombosis, recurrent pregnancy loss. Actually this is having a potency to form a clot like thrombus. Protein C or proteinase deficiency decrease ability to inactivate factor 5A and 8A because factor 5A and 8A are activated by protein C and protein S. Increase risk of warfarin induced skin necrosis if there is especially drop in protein C. Together, protein C cancels and protein S stops coagulation. Okay, so protein S and protein C actually both are anticoagulants. Even antithrombin is also anticoagulant, but you can see the name antithrombin deficiency. So if there is antithrombin deficiency, it will lead to hypercoagulable state, right? Factor V laden, also if there is no factor V laden, that will lead to formation of thrombus, hypercoagulability. When there is protein C and protein S deficiency, because both are anticoagulants, if these both are deficient, that will also lead to hypercoagulable state. Next, prothrombin mutation. If there is more prothrombin, that will lead to more formation of platelet plugs, and that will lead to more hypercoagulability. Okay, there's a point mutation in 3 untranslated region, increased production of prothrombin, increased plasma levels, and venous clots. Antiphospholipid syndrome occurs in association to lupus or primary disease like venous arterial thrombosis, DVT, recurrent fetal loss, increased PTT, false positive cycles. PTT is only increase, means intrinsic side it is increase. So we should see one lab and one clinical criteria to confirm this. That is anticardiolipin, lupus anticoagulant, anti-beta 2 glycoprotein. Anticoagulant is coagulation assay. ELISA test, you can also see increased PTT. Okay, we do mainly ELISA test to anticardiolipin and anti-beta 2 glycoprotein. Let us continue with blood transfusion therapy. So whenever you're giving packed RBC means whenever there is acute blood loss or severe anemia, you're giving directly packed RBC, or it is mainly having more of hemoglobin, more oxygen binding capacity. Platelets, when you give platelets, of course, when the platelets are low, so you want to increase the platelet count, stop significant bleeding, or whenever there is thrombocytopenia or qualitative platelet defect. Next, fresh frozen plasma or prothrombin complex concentrate. You they increase the coagulation factor levels because you're giving frozen plasma, right? It will have all the contents of coagulation, and also that is, you can see your coagulation factors. Also they'll have plasma proteins. PCC generally contains factor 2, 7, 9, 10, like all are vitamin K dependent, right? Protein C, protein S, all this. So clinical use can be used in cirrhosis, immediate anticoagulant reversal. If you want to reverse anticoagulation immediately, then give fresh frozen plasma. Next, you can also give vitamin K. Cryoprecipitate. It contains mainly fibrinogen, factor 8, and factor 13, von Willebrand factor, and fibronectin. So it is used especially in coagulation factor deficiencies, mainly involving fibrinogen and factor 8. Okay. Albumin is given to increase intravascular volume and oncotic pressure. So it is used mainly in post paracentesis therapeutic plasma pheresis. So blood transfusion risk include infection transmission. Okay, so if you are giving infected blood, or also transfusion reactions may occur, or also iron overload may lead to secondary hematochromatosis, because already you know that iron will be present in our blood, and now if you are taking extra blood, extra iron into the body, that is hemochromatosis. And also hypokalemia. Why? Because citrate is a calcium chelated. So we already in the donated blood, we will use citrate, so it may lead to hypocalcemia and also hyperkalemia, because RBCs may lies in blood units. So when RBCs lies, that will lead to hyperkalemia. Next, coming to leukemia and lymphoma. Leukemia means lymphoid or myeloid neoplasm, which is involving the bone marrow, and they are actually found in peripheral blood. Okay, so they are found in blood, and they are neoplasm with involvement of bone marrow. Whereas lymphoma means it is a tumor arising from lymph nodes. Okay, inside the lymph node. Variable clinical presentation arising in atypical sites, because lymph nodes are present throughout the body, anywhere it may occur, and it may also show same like leukemic presentation. Here you can see lymphoid or myeloid neoplasm. Lymphoid in leukemia. Lymphoid means it may involve T cells, B cells, or plasma cells. Myeloid leukemia means it may either involve your you know ben, that is granulocyte, or it may involve the platelets, or it may involve the platelets, RBCs, anything. Okay, so now coming to Hodgkin and non-Hodgkin lymphoma. What is Hodgkin lymphoma? Both may actually have B signs and symptoms, that is low grade fever, night sweat, weight loss. These are like non-specific symptoms, because you can have fever, night sweats, weight loss in anything, right? But how to differentiate them as Hodgkin and non-Hodgkin? Hodgkin, you'll have single group of nodes with contiguous spread, which is strongest predictor, that is better prognosis, and this is characterized by Reed-Steinberg cells. So these are Reed-Steinberg cells. You can see they are called owl eyes. You can see how they are looking. They're like owl eyes, and they're having bimodal distribution. It may occur in young adults greater than 55, and also, it can occur in young adults and also greater than 55 years. It is associated with Epstein-Barr virus. That is important. Coming to non-Hodgkin lymphoma, here multiple lymph nodes are involved. So here only single group are involved. Here multiple are involved, and that may also have extra nodal involvement, which is common. And non-continuous spread, there's continuous spread, and there's worse prognosis. Non-Hodgkin worse. How to remember this? Because non-Hodgkin is including multiple lymph nodes. If multiple lymph nodes, then worse prognosis. Here you should remember one thing: it is a lymphoma. That's why it is involving the lymph nodes. Only one lymph node Hodgkin, many lymph nodes non-Hodgkin, many lymph nodes so worse prognosis, only one lymph node so good prognosis. And here only one lymph node reached Stenberg cells, bimodal age, Epstein-Barr virus. Here majorly involve B cells, rarely T cell. Okay, majorly involve B cells. Can occur in children and adults. May be associated with autoimmune diseases and viral infections like HIV, Epstein-Barr, HTLV. All these viruses are involved, and also autoimmune disease may also involve here, and also viral infections. Okay, very important. Non-Hodgkin B cells are involved here. Now coming to Hodgkin lymphoma, as I said, single node of lymph is involved. Here B symptoms are present, most common in male. Macrophage will activate, and that will lead to hypercalcemia. Cytokines generate reactive cells. So the Reed-Steinberg cells, they are distinct tumor giant cells, bilobe nucleus with two halves of mirror images. So they are like CD15, CD30 positive. I remember like that. One is CD15 positive, one is CD30 positive. Both are B cell origin. So remember, Hodgkin lymphomas are B cell origin, and they show B symptoms. Okay, and subtypes are nodular sclerosis, that is mediastinal mass. Also in chest x-ray you can see mediastinal mass, and lacunar variant of Reed-Steinberg cells. Reed-Steinberg cells only are present, but lacuna is also present around them. If there is nodular sclerosis, most common in female. Nodular sclerosis, so nodules are present in female, like that you can remember. Mixed cellularity is eosinophilia, seen in immunocompromised patients. That's why immunocompromised there is eosinophilia. Eosinophils are increased. Okay, and lymphocyte rich, as it is rich, it has best prognosis, and lymphocyte depleted, as it is depleted, worse prognosis, seen in immunocompromised patients. In immunocompromised patients you can see lymphocyte depleted, and also you can see mixed cellularity. That is important. Most common lymphoma in Hodgkin lymphoma in female is nodular sclerosis, but overall Hodgkin lymphoma is most common in male with Reed-Steinberg cell 15, 20, 30. Okay. And one more thing, cervical lymphadenopathy is most common. If you remember, Hodgkin lymphoma only involves single lymph node, that is cervical lymph node, like that you can remember. And the stage is strong predictor of prognosis. Bimodal age distribution already discussed. Nodular lymphocyte predominant. Popcorn cells express CD20 lymphocyte predominant. So popcorn cells are seen in where Hodgkin lymphoma. Treatment regimen ABVD. ABVD means adriamycin, bleomycin. Actually, these are cytotoxic antibiotics. I'll discuss pharmacology also later. Next, you can use vinblastine, dacarbazine. Okay, vinblastine is microtubule inhibitor, dacarbazine is alkylating agent. So these are the drugs which we use for Hodgkin lymphoma. In the next session, we'll start with non-Hodgkin lymphoma.